guess we'll get started. So my name's Casey. I do headache procedures, and that's the subject of this talk. But I also spend a lot of my time in lab trying to figure out how migraine works. And so whenever we talk about anything, I'm going to subject you to a little bit of that, because I think also it just helps to know what do we know, what do we not know, and why are we doing what we're doing, right? Because some of this stuff is not intuitive. So first thing, making sense of migraine, and I'm probably dating myself with this, but it still expresses things better than I can, a picture's worth 1,000 words. This gentleman is an entrepreneur in a competitive industry, and he, like everyone, wants to do better than his fellow heavy metal guitarists. And so he wants to be louder than the rest, and so he designs amplifiers where you go to 11 instead of 10. And of course, the logic of that is a little faulty, but it actually expresses something relevant to migraine, which is that the volume of the amplifier, the volume knob in migraine is turned up beyond what is normal. And the way we express that in the language of neuroscience is the gain is turned up. It's the same thing. We all have volume knobs for every one of our senses, and for some reason in migraine, the volume knobs for all of these are turned up, and we are still trying to figure out why. We can divide this into really 3 components, and I think this is important when we think about migraine, because it's really not just a pain disorder. It's not just a headache, right? So there's sensory gain, there's a sensory volume, and that's intuitive. We all understand that. Throbbing pain, all sorts of other sensory amplifications that we'll talk about. The other one is homeostatic or autonomic. So what is homeostasis? It's the body trying to keep itself in a normal equilibrium. That's done through the autonomic nervous system, so fight or flight, or rest and relax, sympathetic, parasympathetic nervous system. The biggest manifestation of that is nausea and vomiting, but I'm sure you can see other manifestations of it in your own headaches or in those of your loved ones. There's flushing, there's pallor, the eyes run, the nose runs. There's all sorts of stuff going on beyond just the pain. And then there's what we call affective, right? This is not just a disorder of the senses. It's not just a disorder of your homeostasis. If you have chronic migraine, if you have headaches every single day and you're not feeling depressed, then I want to know what you're smoking. I mean, that's really, it's an affective. When you are in pain, it is an affective stimulus, a negative one, right? So we spend a lot of time trying to understand these truths in a scientific manner in the lab. And we give this a lot of thought, and we just put something out just recently on this. And we don't need to go into it, but I'll touch on things a little bit. Basically on the left here, let me see. Aha, that works, okay. This is the way we conceptualize migraine. It's not just a headache, it's not just this red rim around the head. It's that touch hurts, right? Your hair hurts, right? So a normal touch in gray turns red when it hits you. Sound hurts, phonophobia, right? Light hurts, photophobia. Osmophobia, smells are either amplified or they're rendered noxious in a weird way. And of course there's nausea as well, which is basically sensation from the gut. So this is not even in the head, this is your whole body, right? Because you can have allodynia in your hands, you can have allodynia in your feet. And like I said, we conceptualize this, if we move to this middle panel, in neuroscience as gain or volume control. And this is something that takes place throughout the brain, often not just in different parts of the brain, but in the brain as a whole. You can turn up or down the rheostat. And an intuitive way of thinking about it is just think about your vision. When you go into a dark room, your pupils dilate to let in more light. When you go into a bright room, they constrict to let in less light. That's just one little feedback loop of hundreds in the brain that are constantly dynamically modulating the gain, the volume that we experience. That's normal sensory function. For some reason in migraine, that goes awry. And ultimately, if this volume knob problem gets persistent or gets entrained, you have what we call plasticity in the nervous system, what the rest of us just call learning, right? You can have, our brains are designed to learn, our brains are designed to sense, and our brains are designed to learn. Migraine is a disorder where the sensory system and also the autonomic nervous system, for some reason, are sending too much of a signal. And if the brain and body learn to do that, if they invoke plasticity mechanisms, then you've got chronic migraine. You've got a perpetuated, grooved-in state of increased gain in the nervous system. So that's just to sort of orient ourselves, right? Where are we? And again, like I said, we spent a lot of time trying to figure out, because we don't know. We really don't know. This whole paper we wrote is a hypothetical piece. It's taking together what we know, and then trying to make an assembly out of it, because we really don't understand migraine very well. But the only part I want you to take from this monstrous diagram here is the whole brain is affected. Different parts of the brain. The sensory brain, the autonomic brain, the affective brain are all affected. They're probably affected dynamically, interrelatedly. All these things are lighting up at once. But if you really focus on the key part for our lecture today, how is this triggered? Our field for many, many years has focused on what we'll call central triggers. What does that mean? Triggers inside the central nervous system. So inside not only the skull, but inside the dura mater, the material that invests the skull in a fluid, the brain in a fluid envelope inside the skull. So it's the brain and the spinal cord. Everything else is periphery. So the nerves, your vessels, all the rest of your body is the periphery. Our field, for whatever reason, we're human, we just have biases, and groupthink happens. We've been focusing on these central triggers for a long, long time, but what sort of practice is starting to teach us is, yeah, these are real. These central triggers are real. One of probably the most known one is the migraine aura. This is something that's happening inside your brain, and it is undoubtedly triggering attacks. But majority of patients don't have migraine with aura, and the majority of people with migraine with aura also have attacks that aren't aura triggered. So there's probably other ways that we're triggering migraines. And that's what I want to highlight here, is that there are peripheral triggers outside the central nervous system. And that's what we're targeting with migraine procedures. And this diagram goes on, but basically either one of these two arrows can lead to activation of structures in the brainstem that are meant to just take care of the organism, that are surveying the organism at all times. They shoot up to higher centers that are involved in autonomic outflow and sort of regulating what's going on in the organism. Then they shoot up, and this is all happening pretty much at the same time. These shoot out to other alerting and arousal centers in the brain. And at the same time, they're activating our emotional response centers, because those are basically the same. Our emotional response centers are meant as ways to respond to threats in the environment, among other things. And then finally, all these pain signals are going up into the sensory cortex, and they're propagating through different sensory cortices. So these are regions of the brain that are meant to process sensory information. So basically, this whole network gets activated. You don't need to know that for, in the literal sense for what we're talking about today, but I hope it provides some context. So, bottom line from this is, you can have triggers in the central nervous system, you have triggers outside the central nervous system. And this, I think, speaks to what we're dealing with. So this is a old Gray's Anatomy, the original Gray's Anatomy, the actual anatomy textbook, depiction of a skinned head, and all this stuff in yellow is nerves. And basically every creature from worm onward has the same sort of features that we do. There is a much greater concentration of sensory structures toward the head end, because worm doesn't even have really a head, although it does, than other regions of the body. There's just more. We're enveloped by a web of nerves, right? There are also vessels here, and that's important to realize too, because there are nerves on the vessels. And I would argue that if you stimulate a blood vessel around the head, that duplicates the pain of a migraine attack a lot more than tweaking a nerve. And that's probably because there are nerves in them, and the vessel is its own little environment that reacts on its own. So, like I said, our field is focused for a long time about how there could be triggers inside the head for migraine. And I think maybe this is intuitive because it does feel sometimes like the head, it's the inside of the head rather than the outside that's hurting. And that sometimes it's exploding. And indeed, there are pain-sensitive structures inside the skull. This is work done in 1940 that could never, ever, ever be done again because it would not pass an institutional review board for good reason. These were, the quotes from this paper are awesome. You can look it up, but it's this sort of hideously but hilariously paternalistic medicine of the 40s. They're talking about they were doing surgeries on primarily epilepsy patients, and they got their consent, or they said, to stimulate with electrodes, basically zap different parts of the inside of their skull while they were going at the tissue that they were going to take out to treat epilepsy. And what they found as they stimulated these regions is very interesting. So basically, take a look at these heads. These are beautiful figures too. Look at these heads and the shaded areas. The shaded areas are the areas of pain. So clearly, if you stimulate, this is the dura, these are veins, these are large blood vessels, this is a middle cerebral artery. If you stimulate the lining of the skull, the dura that lines the skull, you get these exquisitely migraine-like locations of pain response. I mean, I'd say probably if you were to pick, this what we call periorbital around the eye and sort of occipital back of the head pain, or the two of the nodes in that pain network that most hurt. So you can do this by stimulating the inside of the skull. I should note here, though, these structures are all still considered peripheral. These are not in the central nervous system. These are nerves lining the skull and on the vessels, but they're actually not inside the brain itself. If you stimulate the brain itself, in most parts of the brain, you won't feel pain. There's a couple tiny exceptions, but that's the rule. Now, these folks also stimulated outside the skull, and look what they got. They got similar patterns. So you stimulate the middle meningeal, the superior temporal artery. That's the one you can sometimes feel throbbing up here. You get pain right around that forehead and around the eye region. If you stimulate some of the other branches of the arteries, you get the same thing. You get this periorbital pain, temporal pain, and occipital pain. So stimulating structures outside the skull can cause migraine-like pain. So why don't we try to turn down the volume on those structures outside the skull? For years and years, headache docs have not done this. And finally, we're now starting to do this eminently logical thing. So what are some of the peripheral treatments? Treatments where we pretty much know we're not treating the central nervous system. What's a contrast to that? If you're taking amitriptyline, for example, amitriptyline is a migraine preventive drug. It goes to all parts of the body and undoubtedly does get into the brain. So a drug like that, we're pretty sure at least some of it's getting in the brain, and it's some of its or all of its effects may be actually occurring in the brain. A caveat is that this drug is going everywhere in the body, so it could also be acting out in the periphery as well. But we have treatments that we know are going everywhere. Most of the drugs that you take, topiramate, amitriptyline, the preventive drugs, go everywhere, and we suspect they're going into the brain, and they could easily be doing stuff inside the brain. What we're going to talk about here is the spectrum of treatments that we are pretty sure are not going into the brain, and yet they work for migraine treatment. By the way, we're talking about migraine because it's the most common condition. It's the one we know the most about. But most of these principles at least apply to other forms of headache, to cluster headache, to tension headache, cervicogenic headache. We can be more definitive about migraine. So, botulinum toxin, or Botox, you've probably all heard of that. That is a large, complicated toxin molecule that's injected specifically just under the skin. It is extraordinarily unlikely that it's getting into the central nervous system. Nerve blocks, ditto. Sphenopalatine ganglion block. These are the ones we're actually going to talk about in a little more detail. Same. I mean, for nerve blocks and sphenopalatine ganglion blocks, it's possible that vanishingly small amounts could get into the bloodstream and thus get into the brain, but very, very unlikely. And then just to set our context, it's not just these treatments that we're going to talk about that are likely peripheral or not getting into the central nervous system. Biggest example is triptans, right? Sumatriptan, naratriptan, Emerge, all these drugs. We used to go through contortions trying to understand how they would get into the central nervous system, but the fact is they don't penetrate the blood-brain barrier, which is what keeps a lot of drugs out of the central nervous system very well at all, and yet they work just fine. A lot of these devices that I think we're going to have another talk on devices. And these are now very fashionable, and a lot of them do appear to work very well. These are acting outside the central nervous system. The one on the bottom, transcranial magnetic stimulation, claims that it's acting inside the nervous system. Just trust me, from the scientific point of view, I think that's probably not true, but it doesn't have to. It can just act on the nerves at the back of the head where it's discharging. So a lot of these treatments that we're quite excited about are not acting inside the central nervous system. Finally, one that we're probably most excited about, the CGRP antagonists. Have you guys heard about these? These are new drugs coming along as preventives. CGRP is calcitonin gene-related peptide. It's a substance that's released when nerves around the head, also the rest of the body, when they fire. And it basically perpetuates the action of those nerves. Anyway, these, I should mention, all these are color-coded. So red is FDA approved, gray is not. These are not yet FDA approved, but we're pretty sure they will be. Some of these are never going to be FDA approved. And actually, it's probably good to take a quick aside to talk to you guys about that. The reason is we all, as patients, physicians, caregivers, need to know about the economic environment we're in now, right? I used to try to put my head in the sand. I'm a physician, I'm a scientist, I don't need to know about the billing. No, it's incredibly critical, because if we don't know how to fight for the treatments that we know are good, we're going to get trampled by payers usually, or even by the healthcare system. So I'm pointing this out because some treatments are going to be relatively easy to get pre-authorized for. They're always pre-authorized. Pretty much any procedure or device it requires pre-authorization. Why? Because they're expensive on a point basis. Botox, just the fluid in Botox costs $1,200, and that's with good reason. This is one of the most potent toxins known. You want the manufacturing process to be pretty tip-top. There are fewer generic manufacturers in this realm. Why that is for Botox, I don't know. Probably because it's just probably so expensive to make. The devices, some of them are quite complex. So there's reasons why things are expensive. Payers freak out at this because they see a large point cost, or their algorithm does. Maybe it's just an AI network that's doing this. But what they often fail to see is that if an expensive procedure keeps someone out of an ER, what's an ER? It's $5,000 a pop, What's a stay in the hospital afterwards? Tens of thousands of dollars, right? For some reason, that doesn't seem to enter the calculus. I don't know why. But in this realm, I think we all need to basically be proactive. So we have template appeal letters. We try to work with you all. We try to also work with our back office folks who aren't always aware of this stuff. And they, any hospital system wants to be in the black, and so they'll bill reflexively and automatically, and so we're always working with them to try to reduce costs. But I think the subject of cost it's been this sort of taboo issue. It feels gross to talk about. But I think if we don't talk about it, if we don't sort of destigmatize it, we're all going to be worse off. We're not going to be able to treat the way we think is right. Sermon over. But hopefully it's important. So there are things that are approved, there are things that are not. The things that are not approved, things that will never be FDA approved, nerve blocks, for example. Why will they never be approved? Because to get FDA approved, you need 2 randomized controlled clinical trials. How much does that cost? Tens of millions to billions of dollars? What gets put in nerve blocks? Lidocaine, bupivacaine for the most part, how much do they cost? Cents per bottle, pennies per bottle, versus Botox, $1,200 a bottle, right? So there's no economic forces mediating the clinical trials that would justify the use of trigger point injections and nerve blocks. Anecdotally and clinically, we know these work, and there's some evidence to suggest it, but the quality of evidence necessary for a trial isn't there. So that context hopefully also is helpful. Do we think it doesn't work? No, we wouldn't be doing this. We wouldn't be poking people in the head with needles if we thought it was useless, right? Okay, so let's get into the actual procedures that we do, and there are 3 main ones at that right now. The first one is botulinum toxin, or Botox. That's probably the most common procedure we do. And this, I'm just throwing up the template, because this is, if you go on the web, this is what you see. There's these templated spots, and they're excellent spots. And it's 155 units of Botox. We don't do things this way now. We've evolved a little bit, but this is the template, and we go to these places, but we tune things more now. Why is it that these spots are there? Why were these templates made? It was really trial and error. So Botox started out being a procedure, cosmetic procedure. That's how it made its way to headache, ironically. Folks who were getting Botox to the brows started saying, gosh, my headaches are better. And all of us headache docs said, ridiculous. It's these cheesoid cosmetic people. They have a profit motive. This is fiddlesticks, whatever. And we were dead wrong. We were absolutely wrong. So taking the spots that the cosmetic docs used, and they know way better than we do how the muscles of the head are strung, and then adding different places that people talked about as hurting, they came up with these templates. These are an excellent start. But we've learned a little more over time. And so what do we do now for Botox? You'll recognize some of these spots are familiar from the template. Others are not. And what I've done is I've color-coded things. Red, which I don't know if you can really distinguish here. Red is typical sites that we do, and orange is sort of more optional ones that aren't very frequent, but in any given person, if their pain patterns are happening there, we can customize. How do we customize? Well, Botox comes in 100 unit vials. They're measured in units. These are sort of arbitrary units. To deliver 155 the standard treatment, you need 1 vial plus a little more than half of another. What happens? Then there's all this other stuff that gets wasted, 45 units that get wasted. What we've learned is that we can distribute those 45 units in ways that A, do not cause weakness, right? Because that's a big side effect of Botox. But B, enhance the treatment and customize the treatment. So these are templates. For most people, it's really a fingerprint. It's an individual and changing with time way we treat. And that, I have to say personally, I love that, right? It's a joy to be able to find the spots that are triggering someone and learn with them what they are. So the cool thing about this is it's actually a learning process. You you start out with spots, you sort of feel the head, you feel places, you go to places that you know are important, but then you talk and you realize, okay, well, actually right here is really bothering me. Okay, well, we can do that. Right here's bothering, oh, well, this is the neck. We don't want to inject right into the neck because that could weaken the neck, but if we treat here and here, we can bracket it. And then the patient starts learning. You start learning, wait, I'm being triggered off here, here, here. So I have folks who come in with little X's on them and dots on them that their loved ones put on, and we learn. And then you basically start getting momentum over the disease. That's a stark contrast with a pill, right? It just goes in, and miraculously pills, I mean, think about how miraculous pills actually are, right? This thing goes into your body, goes into your gut, goes into your circulation, and somehow gets to the place where it needs to do its job, right? That's really quite astounding, and things that we take for granted, right? But this is feedback, right? This is learning. So places we treat, right between the brows, top of the brows. We tend to put less in the forehead because the forehead can droop, or if you put it in different places, it can sort of rise up and people get this sort of Spock brow. So there's a little bit of an art to that. We treat around the temples, right up here, and you'll see, we'll turn to the temples. In some folks, the pain around the eye is really bad below the eye, so we can treat there too. We can treat the jaw in people where they're grinding their teeth or they have TMJ. We can even treat the neck, and now that we've gotten to know this a little better, the front of the neck, which is the place we used to avoid. If you look at the side of the head, the red dots are sort of focused right around here, right where the pain's bad. One place we always add that isn't in the template is right behind the eye. There's a big nerve branch that goes there. We always go behind the ear because there's another branch there. And actually, notice what I'm saying. I'm talking about nerves, and Botox is meant to weaken muscles, right? And that's the justification that it was used with headache. Well, it's probably not, right? So I'm going to see if we have, it's not just that, it's both, right? Let me see if we have, I'll come to it when we do nerve blocks. Just notice the locations here, and then we'll compare them to where we do nerve blocks. They're very, very similar. So you see, we can go to a lot of these template spots, and then we can also customize by placing injections more broadly, or focusing them down, amplifying different regions. And finally, we treat the neck and the shoulders, and now increasingly the back. People come to me saying, I think my headaches are triggered, from my rhomboids here. And then if you talk to them a little more, they're like, well, actually, gosh, maybe they come from here. I would believe it if you told me your headache started with your ankle, because say you sprain your ankle, you're favoring one ankle, you start tilting yourself, that puts more strain on this side of the sacroiliac joint, which in turn you kind of end up curving in an S. That starts putting strain right where your ribs join your lumbar spine. That in turn puts strain on your shoulder girdle muscles, and that in turn triggers all the way up into the head, right? So it really is, the physical triggering of migraines is probably whole body, right? It's just a chained by our skeleton and our muscles triggering process. So we typically focus on the shoulders and the occipito-nuchal junction where the bone and the neck meet, but we can go further afield. All right, so we also do nerve blocks and trigger point injections. And nerve blocks is sort of too strong a word for what we're doing. When you think of a real nerve block, think of the dentist's office where they are making something completely numb such that they can drill down into a nerve and you don't feel it. We're not doing that. We're trying to take the volume knob down. So we put less than is necessary to truly anesthetize a nerve, but we focus on that nerve and we do reduce sensation. So folks will feel, wow, this one's really numb, but this one's not. Or, yeah, I feel like, things are a little bit fuzzy, but they're not completely numb. And what are the nerves we focus on? Well, look at the head is basically, it's not the most felicitous phrase, but it's kind of like roots, tree roots growing around a rock, right? They're just coming up from everywhere. Yeah, I don't want to call people's heads rocks, but anyway, it's just if you can think of a better analogy, please let me know. As an aside, by the way, have you guys noticed that all of these are men that they're showing? All the head models, including some of the Botox marketing materials, show men. I don't understand why that is. If it were cluster headache, maybe. Anyway, we basically go after all of these nerves. We're not trying to block them massively, but we're going after each one of them because while there may be one nerve or another that's more important to anyone with a headache, it's likely that they're all involved. This really is a network disease, inside the brain and outside of the brain. So what you're seeing, is that? Oh, there it is. That's the greater occipital nerve there. That's the lesser occipital nerve. This is the auriculotemporal branch of the trigeminal nerve. We also do the greater auricular nerve, which comes up behind the ear. And look at these spots. These are the same spots that we go with Botox. We put 3 Botox injections here. We put 2 on each side at the neck where the nerves are coming up into the skull. We put, in this clinic, we put them right here and right here. And then you've got the Botox injections right around the forehead. There are 2 sets of nerves that come right above the eye, your supratrochlear nerve and your supraorbital nerve, and they go right up. And so obviously these are incredibly important for periorbital, for around the eye pain, right? So we inject all of these. Some of these are, actually for all of these things, what does it feel like, right? It's, some of these you don't even notice, and other ones are incredibly lit up. And I think that's part and parcel of the pain process. It's a network phenomenon. It's all over the place, and some places will surprise you that they're a lot more lit up than you think. Other places are less. So what do we do in our clinic? Well, these are the locations for nerve blocks. Again, they look quite similar to Botox. As you see, we go to the side of the head. There's not complete overlap, but pretty darn good overlap. So, actually, this is probably a good place to, do you guys have any questions so far on those 2 procedures? Go ahead.
Yeah, so when Botox and trigger point, are they, one going to muscle and one going to nerve?
So originally, that's that. We think they're probably they're going to the same structures, probably nerves and muscles in both cases. And vessels, right? So like we talked about, the vessels have their own muscle inside them, and they have their own nerves inside them. What your question brings up, though, is these are incredibly different substances. So Botox is a toxin. It prevents nerves from firing, and it does that for 3 months. Lidocaine and bupivacaine, the primary constituents of our nerve blocks, as you know from the dentist, they wear off in 2 to 3 hours. So why are these things, why, we're putting them in the same place, why are they having similar effects? Because they do. I mean, we use these nerve blocks and trigger point injections for the same reason that we use the Botox, for sort of long-term prevention of headaches. That's a big mystery, actually, and I could speculate on it, but yeah. But basically, we're trying to treat nerve, artery, and vein, and muscle in these locations. Each of these locations has all of them there. Yes. Mm-hmm. Go ahead.
Are you going to talk about surgically clipping those nerves?
Not in this lecture, although that is it's something I can comment on it briefly. So it's in our sort of neurologist-based headache world, and also in most pain practitioner clinics, a lot of people think of it as run away, this is horrible, these folks are charlatans, this is dangerous, blah, blah, I think that's probably an overreaction. Again, all these fields are guilds. They're little. They have their own culture and they have their own biases. What I do think is really fair to say is that these should be the last of last resorts, right? Because you're killing these nerves, you're avulsing them, or cutting them, and it's a surgical procedure. These things do have risks. That said, this location right here, the one right behind the eye, I almost went up in front of the screen. Look at that. I remembered my lesson. Oh shoot, where is it? This injection right here. This is called the zygomatico-temporal branch of the trigeminal nerve. And this is one that I only learned about by talking to a colleague who did migraine surgeries. And I have seen patients who have done well with migraine surgery. So who am I to say, we should never do these? What I do think is that it really, really should be, because we do have many of these options, that it should be the last of last resorts, just because it can have permanent effects. And we do see folks where things didn't work or things went wrong, and these things happen. I guess one argument for being conservative first is that one of the ways that the surgeons determine whether someone might respond to surgery is they inject that area with Botox. And if they get a response to the Botox, then they go to the surgery. I guess my argument would be, if they get a response to the Botox, maybe use the Botox for a while. And but we used to think Botox was a crock, right? So I think modesty in the face of Mother Nature, right? We don't know anywhere near what we think we should know, and what certain people think they know, right? Any doctor who says they've got headaches figured out is a charlatan. Run away. All right, you had a question.
Yeah. So, as a practitioner, when you have a patient, what kind of helps you make a decision or kind of guide somebody towards Botox versus guiding them towards nerve blocks?
That's a good question. Either one can be used for headache prevention, and that's primarily how we use them. We'll sometimes use nerve blocks if someone's having a really, really bad headache day and they come in. We have sort of a little acute care arrangement so folks can avoid going to the ER. And that's one of our options there. And in fact, that's how we first started using nerve blocks, is because, it's numbing medication, numb up the headache. It was only later that people started saying, well, wait, my headaches were better for weeks, So for the most part, they're interchangeable. The FDA approved one is Botox. So probably if you were to force me, I'd say we'd go for that first, just because it's got more evidence. But like I said, we're never going to get proper evidence for nerve blocks. If someone has really sort of what we call neuralgiform pain, which is sort of shooting pain, we might go first for nerve blocks. In practice, it really, sometimes this is galling to say, but sometimes it's determined by the response of insurance. They say no to one, so you go to another because both of them can work. And that's a sort of a sad reality of how we have to practice these days. But as long as you can get one, that's all right. Any other questions?
I have one right now.
Of course, yeah. Oh, one of these. Oh, geez. Thought you meant another question.
No.
One of these. Yeah. Yeah.
Question.
Yes.
On the nerve blocks, you say they're not FDA approved, but
Mhm.
they are used in the United States.
Yes.
Okay,
Quite a bit.
So if we're given them, I didn't know that until you said it, but
Mhm.
I've had them before, but I didn't know they were not FDA approved.
Mhm.
So I thought everything a doctor would do would be FDA
Oh
approved.
gosh, no, yeah, no, that's an excellent, no, but it's a perfectly logical statement, right? You'd think, right? Most, by the numbers, most treatments are not. It's really the newer ones that have pharma company funding to back these massive trials, or if you look back, and there were 2 beautiful randomized clinical trials of, for example, aspirin. That there have been trials in the past that meet criteria, but for the most part, there's a bias toward new things, and things that are profitable for company, pharma companies or device manufacturers.
It's not necessarily unsafe.
It's no.
That's what I think. If the FDA
Yes.
doesn't approve it, there must be
That's
something
right.
wrong with it.
That's right. And what you can say is it is the best level of evidence. Something that's FDA approved has not one but two trials of hundreds of thousands of patients conducted under the most rigorous circumstances. So we can absolutely say something FDA approved has the best possible evidence for it. We can't say the opposite, which is that something that's not FDA approved doesn't have, it certainly doesn't meet that level of evidence, but that it doesn't work, no, that's, unfortunately, it's, we'd want to have everything FDA approved, but maybe we can get more things, but yeah, we won't get everything. So, antibiotics, certain antibiotic treatments that we trust, all the time, surgical techniques, they'll never get FDA approved.
Well, can I even add, for example, like certain medications, when they do these trials for them to get them FDA approved, they're doing them for like a couple specific purposes, but there's, evidence is shown over time that there's so many other things that they work for, but they're not going to go through that same rigorous process to get FDA approval for these other uses for it, because the medicine's already on the market, and it's already been FDA approved for something, so nobody wants
That's
to.
right. Yeah, that's a very good point.
The dentist's work, that's probably FDA approved then.
No, I think most of those procedures are not, but they're so accepted that because they do work. I guess it's the reason I even bring it up is because payers will use it as a stick to beat us. They'll say, nerve blocks are experimental, and they're really not experimental. They've been used thousands, millions of times. They work for some people, they don't work for others, but that does not mean they're experimental. So I guess they take a good thing, very high levels of evidence, and use it as a cudgel to prevent having to pay for things that are expensive. But again, as long as we know this, then we can come at them. Anyway, so the third procedure I wanted to talk about is the Sphenoid ganglion block. It's a mouthful, and this one's the most recent. And what is this sphenopalatine ganglion? A ganglion is a ball of nerves, and it's a ball of nerves that usually has a common purpose. So, for example, the nerves from all parts of your body collect into something called the dorsal root ganglion right near your spine. That's a ball of nerves that then send their message into the spine that are collecting information from around the body. Your trigeminal nerve, which does most of your inside of your head and the front of your head, goes to your trigeminal ganglion. Those are sensory ganglia. The sphenopalatine ganglion is actually an autonomic ganglion. So you remember the autonomic nervous system? The sphenopalatine ganglion is part of the parasympathetic nervous system. And I can't go into this level of detail, but suffice to say that there's parasympathetic outflow when you have a painful stimulus to the head. And so the reasoning is if you numb up this ganglion, then head pain is reduced. And indeed, in a lot of folks it is. What I should point out here is, as you can tell, all this is trial and error, began with trial and error. There's a reason for it that we either hypothesize in the beginning or more likely post hoc reasoning figure out that this is how it worked. Science and medicine proceed via serendipity a lot of times. But not everyone responds to any of these procedures, right? It's just trial and error in the clinical realm, just like it is in the scientific realm, right? We use these because it's a good bet that you will respond to one of these. And we absolutely believe in these procedures, but always keep in mind, like anything in headache, sometimes it works, sometimes it doesn't. Anyway, people started, there are a couple ways, I almost went out in front of the thing again. People used to do these with cotton-tipped applicators that they just put to the back of the nose, and they soaked these in lidocaine or something else. And actually, we still do that. We do that as the preparatory treatment for the block. what it does is it helps numb up the nose so that when this tubule goes in there, it's a little less weird. And also, it has its own therapeutic effect. It's how we used to do it. There are two different surgical techniques that I won't show you that are more invasive, where they'll go in under fluoroscopy, under sort of continuous movie X-ray. You can go this way through the cheek, or you can go up through there. I used my middle. I apologize. They go up through the roof of the mouth. Those are we don't do them in this clinic. These are done by our pain medicine colleagues who do more invasive treatments. But those are an option. We're turning to these more frequently now because the non-invasive treatments work. So the second part of the procedure is in our case, we use a device called a sphenocath. There's other types of device. This one works better for us. There's nothing to argue against one or another. Unfortunately, this promotional image shows the wrong positioning of this device. It actually needs to go in a little further and a little flatter. But you get the idea. The shape of the device allows you to inject lidocaine numbing mixture, and we add a little bit of steroid and anti-inflammatory and get it right to this ganglion at the back of the nose. And you sort of sit there, and it forms a little cup, and so you fill the cup with the fluid, and it sits there for a little while. Typically we spend 10 to 15 minutes with the applicators, and then either once or twice, 10 to 15 minutes, having filled up the little cup or fossa where the ganglion is.
And you get a Valium first, so you
to tolerate a lot of these procedures are a little bit creepy, right? These are needles to the head, right? A needle coming right above your eye. So I think it's very important with anybody who's doing a procedure, let them know if this is nervous making. What we try to do here is instead of having people seated, which is conventional, we have you lie down and you flip over from side to side, and it's a little more relaxing, and there's also less movement. We can be more precise. But the other thing is we allocate time. I think it's important to explain the procedure, explain the expectations. What can this do? What can it not do? What are the potential side effects? And actually, maybe we should talk briefly about that. Any other questions? Because we're pretty much done with the sort of narrative portion.
How would you decide to go for this block?
This one is, so if you have prominent parasympathetic symptoms. So for example, we use this for cluster headache, which has very prominent, reddening of the eyes, tearing, runny nose. Those are all parasympathetic symptoms. This would be a go-to in cluster headache for those reasons. It's also, as you probably know, migraine can have those same symptoms. They're just not as extreme. So if someone has prominent parasympathetic symptoms, which is basically the tearing, runny nose, redness, then we might go first to this. What other questions about this stuff? So I guess go ahead.
Do you ever pair the...
That's a good question. So there are specific instances where we do not pair. So the one, and this will actually go to the side effect stuff, which I should talk to you guys about. The one thing we never do is do Botox and nerve blocks at the same time. The reason is the one time it was ever reported that someone got anaphylactic shock from any of these procedures was when they were combined. And they think it was because they were mixing the Botox in with lidocaine in a kind-hearted attempt to make it not hurt, but it ended up with a worse response. How do we pair these in real clinical practice is we step them in time. So first of all, if you can avoid needles to the head, do something else, right? But if you've tried other things and this is what you need to do, first try to do just one of these. So do just Botox. But let's say Botox is working great but not sufficiently, or it's working almost to 3 months but then it's fading and you're getting a rebound. So then we'll do Botox, and about 1.5 months in, we'll do either an SPG block or more frequently we'll do nerve blocks. And that seems to extend things out. So we let them work in concert, but not on the same day. Sometimes we do need to add things up. Obviously, the goal is always keep it as simple as possible. Side effects in general, so there's side effects of injections, right? So you could get an infection, right? You're going into the skin. That turns out to be vanishingly rare.
It's so rare that
yeah.
nurses don't even.
We don't
not
use.
required to wear gloves for.
Yep.
injections.
We use gloves just to keep it clean, and because otherwise it'd freak people out if you have needles. But really, your skin is actually way better at protecting you than betadine and alcohol, which just add irritation risk, which is a much higher risk. So infection is vanishingly low. What are more frequent things? Well, as you saw, the head is not only covered with a meshwork of nerves, it's covered with a meshwork of blood vessels. We very rarely go into an artery because we're always withdrawing, and an artery will push back blood if you withdraw. So whenever you inject, you withdraw. A vein is not like that. If you withdraw from the vein will collapse, and so you could still be in a vein and still get a little bit of bleeding from there and a little bit of bruising. The worst case scenario is a little bit of bruising. With Botox, one of the things we watch for is weakening. And this was probably the original reason people didn't use 200 units, is because they didn't know how to use 200 units without causing either the neck to be floppy or the brow to be to lower. Those are the two most likely locations. We've gotten a lot better at that, and we can distribute in ways that make that less likely. Does it happen occasionally? Yes. What do? It fades out. The Botox fades out, and then you don't inject that spot again, and you find different ways of doing it. That's the beauty of being able to customize. People, for all of these procedures, interestingly enough, there'll often be a period of soreness after the procedure for about a week, and it typically manifests in the neck. We're not sure why, but we've got little cheat sheets to help with that. And by the way, most of what I'm describing, most places that do headache procedures will have similar ways of going about this. So you've got hot packs, cold packs, call us if this, check in if this. So there's ways around any of these side effects. By and large, they're fairly mild. And one great thing about this is, except for a few vanishingly rare drug combinations, these don't interact with drugs, with other, with conventional drugs. So you can layer things without being worried about that. I think that's about all I have for you guys. Any other thoughts, questions? All right. Well, I think this will be posted online. Are there questions online? Do you guys ever post those online, or? Yeah? We should think about that. Yeah. Ah, okay.
You have said the CGRP. How is that coming along?
Very well. So there's 4 companies. They're all desperately competing to get first to market because, you guys remember the story of Prozac. That Prozac did a lot better than all the other antidepressants because they were first to market. So they're competing tooth and nail, but more importantly, the data looks incredibly good. So I've been involved in some of the meetings about this, and it looks remarkably, remarkably good. So good that you sort of get nervous, but then there's 4 companies, each with identical data sets. Essentially, they look almost exactly the same, over thousands of patients now. So we'll always be vigilant. When they come out, the aftermarket surveys will give us an indication if there's anything we missed. But the concrete answer to your question is supposed to be early summer. The first one's supposed to come out. Take that with a grain of salt, right? There's always delays. So.
Is that being trialed at the U at all, like in sites here at the U?
No, not at the U. There were trial sites in.
Like when you say like meetings, like what's
advisory boards. So when they bring in experts to sort of sit around the table and gas at them about their opinions about things. The question of trial sites. Typically, the economics of those are complex, and typically trials now are being conducted by private entities because they're places that are probably unfairly called trial mills, where that's all they do. Academic centers are doing fewer trials these days, pharma company trials. They do them, but we're always thinking about it, but it's a cost benefit. Should we be doing that, or should we be doing original research trying to understand the disease and doing the best clinical care? But it's a moving target. All right. Oh, yes, one last question, then I probably should go.
We have some hope that if there are 4 companies competing,
Mhm.
the cost will be reasonable so that our insurance will pay it? But
Yes and
that's
no.
rejected.
Yes and no. So the huge feedback we all gave them is like, make it as cheap as possible because you know this is going to have to get pre-auth. This is going to be, insurance going to fight tooth and nail. They heard us, whether they were listening or not, we'll see. It's going to be expensive because these are complex. They're kind of like Botox in that they're very complex to make. In this case, they're antibodies. So again, something that you really need to be incredibly careful about and manufacture because these can activate the immune system in potentially horrible ways. They're proving very safe, but that's because they put a lot of work into it. It's going to be a pre-auth process. It's going to be like with these procedures we talked about. But because in this case they're going to have FDA approval, each one of them has 2 trials. So that's 8 trials showing that that these things work. We're going to have more of a sledgehammer with insurance than we do, say, with nerve blocks. It'll be analogous to Botox, I think. All right. I think I hope it didn't go over time, but thank you.